Today on This Week Health.
We all know at this day and age how important a strong data governance function is. And I think this recent explosion we're seeing around generative artificial intelligence may be challenging some of that. We've got data lakes and lakehouse models now instead of traditional data warehouse models, that data governance takes a different form or different shape, but you still need it. And it's still critically important.
Thanks for joining us on this Keynote episode, a This Week Health conference show. My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, a set of channels dedicated to keeping health IT staff current and engaged. For 5 years, we've been making podcasts that amplify great thinking to propel healthcare forward. Special thanks to our Keynote show partners, CDW, Rubrik, Sectra, and Trellix, for choosing to invest in our mission to develop the next generation of health leaders. Now, on to our show. All right, today we are doing a keynote show and we have a special guest, Brent Lamm, CIO for UNC Health. Brent, welcome back to the show.
Thanks, Bill. It's great to be with you today.
Same name, different title. We did an interview a little while back and you were, I think the title was CTO at that time. Was that right?
Deputy CIO. Yeah, I had the privilege of serving as the deputy CIO here at UNC Health for, I think, 6 or 7 years when it was all said and done. It was great.
Wow. So talk about the transition. That whole idea of deputy CIO, I was talking to somebody yesterday and we were talking about the interim CIO role, and this person, that's their work. And they said a lot of that's drying up because a lot of institutions, they're taking it to heart and training the next generation and really living out the succession planning within the organization. Talk about your transition a little bit.
Yeah, to that point, UNC Health has done a great job of really prioritizing succession planning and making sure we've got continuity in leadership and doing that the right way. And so the previous CIO, my boss for many years, she, I think this year eclipsed her 41st or 42nd year with UNC Health. She started as a nurse, and really grew her career in a phenomenal way. And so for me, having worked with her over the past decade, she had done a great job of allowing me to constantly take on more and more. And so for me, this transition has been seamless because she had really allowed me to position myself to be able to take over the reins of the team and the organization from day one. And so it was great. It's been a really great transition. In my thinking, it's making me realize one day I'll need to hand the reins over to someone else. That may or may not be something I have any influence over, but it certainly is something that I want to make sure we do, is to set up good succession planning within the team for the future.
Well, I usually start with this question. I'll backtrack a little. Tell us a little bit about UNC Health.
Yeah, so for those who don't know anything about UNC Health, we are affiliated with the University of North Carolina at Chapel Hill, UNC Tar Heels for those basketball fans out there, or women's soccer, and many other sports actually. But so we're about an $8 billion health system now. We've got 14 hospitals at my last count within the system, about 7,600 physicians. We've got hospitals and practices that span from the coast to the mountains of North Carolina, really statewide. We're very focused on our mission of improving the health and wellness of North Carolinians and all of the communities that we serve. We serve all 100 counties of the state as an integrated delivery network, collaborating with and coordinating with healthcare organizations all over North Carolina and beyond.
Are your institutions in what would be considered urban centers? Like Chapel Hill's not considered urban, is it?
I think technically the triangle, for those who know North Carolina geography, right? Raleigh, Durham, and Chapel Hill comprise what's known as the triangle region of North Carolina. And so I think we would call that our urban section. But you did touch on something there. North Carolina, little probably lesser known fact, behind the state of Texas, North Carolina has the second largest rural population in the country. And so we really do have a bimodal mission of serving the urban parts of North Carolina, the triangle specifically being the centerpiece, but also all of the rural parts of North Carolina as well. And the vast majority in terms of numbers of our hospitals are actually in what would be considered rural North Carolina. And how we coordinate care for rural North Carolina is really important to our mission.
The Triangle is still one of the fastest growing areas in the country, isn't it?
It is. It absolutely is. I don't know if I have my facts up to date on this, but at one point a few years ago, the Triangle region was per capita the second fastest growing municipality area in the country, behind somewhere in Texas.
Yeah, yeah. I was in Charlotte last week, and I always count the cranes. That's how I tell if a area
Yeah,
is growing.
yeah,
And clearly, Charlotte's growing. Every
yeah.
time I'm in the Raleigh, Durham, Chapel Hill area, you just see it's continuing to
Yeah.
just continue to grow, and a lot of organizations are planting with the education, with all the education that's around there. It's a great place. I think people go to college there and then decide, I want to live here, and so it's a great source of talent.
There are very few people who move to North Carolina and decide to leave. I will tell you that it's an easy place. I'm a native, so I'm biased as can be, but it's a wonderful place to live and raise a family.
All right, let's talk about top priorities.
Yeah.
And the thing I love about talking with you is because you do bridge that gap between rural healthcare and urban healthcare. Talk a little bit about what the top priorities are
Yeah.
from a UNC Health perspective at this point.
So I would say the first one is as a perfect segue from our previous dialogue there. It's access. So we really, as the state is growing, as the Triangle region continues to boom and grow, we have more and more citizens of North Carolina that we need to provide high quality healthcare services for every day, and it's growing every day. And so continuing to keep up with the demand and access for folks moving here in the aging population, it's really, really a challenge. Access is a huge priority focus for us right now. And then, secondly, I would say affordability. Like every other healthcare system across the country, this has not been a fun year from a fiscal perspective. It's been tough. We are no different than everyone else who's having to navigate these headwinds across the industry. And then I think our third, probably biggest priority is provider and teammate burnout. Everyone is dealing with this one as well, with staffing shortages across healthcare and the digital tools that we love to talk about and we really are using to drive positive transformation for our patients. They do have a side effect, and that's a toll on our providers and care teams at times, in terms of it's another channel of communication and another task on the plate for a lot of our teammates and providers every day.
So let's talk about some of your remote locations. You said you go essentially from the sea all the way out into the mountains. Let's assume I live in a mountain area. I'm probably an hour from the closest UNC campus and whatnot. If I'm seeking care, is it typically driven by an app on my phone? Is it driven by seeing something on a billboard? Is it driven through partnerships? How do you educate me on how I gain access to UNC
Yeah.
clinicians?
Well, first and foremost, I think we're very fortunate in that UNC, as a broader ecosystem, has a tremendous brand recognition and reputation within North Carolina. North Carolina, many, many years, decades ago, made the decision to invest in higher education. We had great state leadership who made that a priority. And that really permeates today across the state, in that there is this, I think, for most North Carolinians, or at least many North Carolinians, still a strong affinity for the UNC brand and all that stands for with our mission. So that first and foremost, people know typically in North Carolina the UNC and UNC Health brand. But yeah, we do absolutely lean heavily on our partnerships. We the provider of last resort for the state of North Carolina. And so we serve all 100 counties of the state, like I mentioned earlier. And we've got deep relationships with providers and hospital systems all across the state, and are very proud that we partner, with them. Even where we compete in some markets with others, we partner very strongly as well. So it's brand recognition, it's partnership. We do have a mobile presence now we're very proud of. We've launched within the last 4 or 5 years that has grown dramatically. We have a UNC Health mobile app that our patients can download no matter where they are. It allows them access to 24/7 virtual on-demand care. Has, urgent care closest to me, the ability to reserve a spot like Open Table, My Chart access immediately, et cetera, GPS right to the door of whichever UNC Health facility you're going to go to, et cetera, et cetera, et cetera. Common capabilities, I know, in today's digital age, but we have it available, and we actually are really proud. We just actually won the CIO 100 award for what we've done with our mobile presence, and I'm excited for the team with all the work they've done to really get that out there.
It's interesting because, I mean, standing up a mobile app today is not all that difficult, but a bunch of the things that you mentioned operationally are on-demand virtual care. How did you go about doing that? Because that's an operational challenge for a lot of health systems.
Yeah, I mean, that's actually a really good story for us. We did something that a lot of organizations do, and no matter what the technology arena or area, we partnered first. We partnered with a third party who could help us bring that provider capacity to the table to help us get there. And just within the last year, we've pivoted now to where that virtual on-demand care is now being fulfilled by our UNC Health physicians. So it was a partner early, and then transition, internalize, bring that back inside, and make that a seamless transition for our patients.
But the other thing that's challenging about it is the internal systems and tracking it. A lot of the internal systems that we're using weren't really designed for that workflow. How did you address some of those challenges?
Yeah, we worked with our third-party partners to really make sure we got everything into our Epic electronic health record system. So to the providers, it wasn't always in the way they wanted it. We all know the dreaded media tab within Epic. For those of us who worked with the Epic system, we made that work, if you will, as best we could at the beginning, and then we gradually got it better. And now everything happens within our Epic at UNC system. It's all done just like a physical encounter at one of our practices.
I was talking to a CIO and he was asking me a question about how do we improve the digital literacy of our patients? And I looked at him, I'm like, I'm not sure I even understand the question, because I see like 3-year-olds with an iPad navigating like they're seasoned pros. And did you end up having to write portions of your application?
We did not do any custom code development. No, we did everything working with third parties and building within Epic and our integration vendor solutions. But if I could, Bill, just take off a little bit on your comment there. Just like 3 weeks ago, I was rounding with one of our hospital executive teams, and our hospital CEO at our facility in Goldsboro, North Carolina, he asked me, he said, Brent, what's the MyChart or patient portal activation rate? Does it really vary between like the Triangle and the rural counties? And I hadn't, it hit me in the moment, we hadn't really looked at that. So Microsoft Teams messaged one of our analytics leads and directors and asked that question. And by the time I got back to the office that afternoon, the team had a nice Tableau visualization put together, and I was blown away. It was amazing how homogenous the percentage of activation rates are across all 100 counties. And so it showed me, it demonstrated to me that there, at least for us, there's not that much of a divide between who's using these digital solutions between our urban and rural settings.
I love that you did a Teams message out there. It sounds pretty easy for people. Oh, and I got back to the office and there was all the data and I could see how it was all there. Again, I know some of the tools you're using, it does have that data available, but I understand the complexity of data within healthcare. Are there areas you feel like you're leading out with regard to the use of data in the delivery of care in your communities?
Yeah, the first area that comes to my mind, we're very proud of our data and analytics team. It's been a bright spot for us and something that we started a real focused journey on with the advent of our enterprise data warehouse back in 2008, 2009. And we've really pushed hard on that to mature every year. We started our data science team with a team of PhD and master's data scientists back in 2015. We've been invested heavily in that space, machine learning, most recently AI, generative AI. But one of the maybe less sexy parts of this that I think has worked really well for us is what we call our analytics community. So we took the approach that we'll never be able to satisfy all of the demand for data, reports, and analytics within a centralized IT and shop, right? Whatever capacity we create, the demand will be higher, right? And so we took a really strong approach to saying we've got to have folks embedded within that hospital, within that department, within that administrative unit, within that clinical unit, who actually have the ability to work with the data, to do that ad hoc analysis, to create the kinds of reports and visualizations that are needed in real time to help move things forward within that given business operation or clinical operation. And so we now have over 450 teammates across the system that are not in the central IT organization. They're embedded in dozens of departments and units of the organization, but they get a common set of training. They use common tools. They use common data sets. And we really work hard. We have a manager of this community within our team who really is sort of the spearhead of all this. And she does an amazing job of helping them connect as this virtual analytics organization. So she's got bi-weekly, we call them TAC talks, right? The analytics community talks where there's information sharing. Our team talks about here's a new tool or here's a new data set or updates we've made to a given data set. We use Microsoft Teams within that community extensively for them to collaborate with each other. They've got tons of teams and channels dedicated to different topics. And any of those analysts have the ability to request online what we call a TAC consult to work with our team who might have a little bit more deeper technical expertise on a given topic or subject that they're working with. And so that has exponentially multiplied our capacity to be able to work with data and analytics sort of at the source, if you will, where that information is needed for that operational or clinical manager or director or executive.
I suppose you support research as well, UNC being a research institution. Is that outside of UNC Health, or do you act as a source of anonymized data for those teams doing that research?
Yeah, in fact, not to get long-winded about it, but my journey to UNC actually started with this exact topic. So I left IBM back in 2009 after a wonderful 10 years there to come actually help stand up our research informatics area right around the time that we were launching our enterprise data warehouse with our patient and administrative data. And so that has just grown wonderfully since 2009. And so we have a research informatics team within the School of Medicine on the university side of the fence within the broader UNC ecosystem that works collaboratively with our UNC Health IT team and analytics team. They really are like another part of our team, and they really do all of the data mining analytics for IRB approved research studies or work preparatory to research, et cetera, and really have gotten to really a strong assembly line of being able to provide data sets to our research teams. To your point, UNC, we're a top 20 NIH funded academic organization. We're number 6 in terms of public institutions across the country for NIH based research. It's a very important part of our mission.
Well, let me ask you this. You're going to give away some free consulting here. So some of your peers struggle in this area. And let's assume you were standing this up again. What were some of the key principles? What were some of the key design criteria in order to do this correctly? And what have you learned since then that you've adjusted along the way?
Yeah, I think one thing probably that stands out to the most, and Rachini Musavi, our chief analytics officer on our team, she's going to enjoy this part because she tried to tell me for years how important data governance was. And for a while there, years ago, I'm just not getting this. I couldn't quite wrap my head around it. But obviously, we all know at this day and age how important a strong data governance function is, and making sure that the data that you're using at the enterprise level for leaders to make decisions are certified, they're high quality, they're well curated. I think this recent explosion we're seeing around generative artificial intelligence maybe challenging some of that. We've got data lakes and lake house models now instead of traditional data warehouse models, that data governance takes a different form or different shape, but you still need it. And it's still critically important. And I think that maybe was one of our mistakes early on. We didn't quite do enough there. And I think if we were going to go back and redo it again, hindsight being 2020, I think we should have been a bit stronger and invested a little bit deeper in that space.
Yeah, it's a great topic. Data governance is a great topic because it's becoming, uh, if it's becoming vogue again, in vogue, I guess is terminology. We'll get back to our show in just a minute. Ever wonder how technology can reshape the patient experience? Join us for our next live webinar, The Patient Experience, a Technology Perspective, on July 6th at 1 p.m. Eastern Time. We're bringing together expert speakers to dive into the intersection of technology and healthcare. We're going to explore topics on digital health tools and the impact of AI, blockchain, and other things around this. Whether you're a CIO or part of a healthcare IT team, we think you will gain practical insights from this discussion. Don't miss out on this conversation. Register today at thisweekhealth.com. We hope to see you there. Now, back to our show. You mentioned cost of care being one of those priorities. I'd love to just entertain a little bit of what are some of the things we can do around the cost of care to keep care affordable in the communities that we serve?
Yeah, no, that's a great question. It's the things that we're thinking about right now. We're working really hard to leverage automation as best we can in our revenue cycle. I think there's a lot we can continue to do there. We're all using some form of computer assisted coding or other more advanced capabilities from the vendors today. But I think there's more we can do there. We just had a really positive success story around this with implementing Epic Payer Platform. We had a great partnership with one of our payer partners. We've seen a decrease in denial rates from 8% to 2% working with that payer partner through the collaboration that we've done with the payer platform technology. We just rolled out another automation solution. This one we actually use as a service. It helps us with prior authorizations for procedures. And certainly many procedures in healthcare have a high cancellation rate at the last minute due to prior authorization not being finalized in time. I don't think we're alone with that challenge in healthcare. And we're working really hard to implement solutions to get that down. We've seen some early success with that as well. I think just general back office administration, there's an opportunity to reduce costs. Our service desks, we're really rethinking those HR, IT, et cetera, facilities in terms of what we could do with the generative AI chatbot capabilities that are readily available now. I don't know that there's any one magic bullet to addressing affordability. Our old CFO used to say 20 nickels makes a dollar. And I think that applies in healthcare now. I think it's how do we continue to push on every one of these fronts to really figure out how we get that full dollar when it's all said and done.
It's interesting for our 229 project meetings. The CIOs each present for 10 minutes. And one of the CIOs said, I don't really have anything exciting and innovative to share. I said, well, what really is the mark of your institution? He goes, we're operationally excellent. Like through this difficult time, we've been profitable. And he goes, because we are operationally excellent. And I'm like, those are probably the sexiest terms that a hospital administrator could hear right now. Talk to me a little bit about pop health, social determinants, and those kind of things. I know you guys, because of the nature of UNC Health and you being in all those counties, you're probably looking at those numbers pretty closely. How are we driving better population health outcomes across, I guess, the entire state?
Yeah. So this is a bright spot for us. UNC School of Medicine and UNC Health, we have really been a leader in primary care for a long time. Where I think our family medicine program is perennial number one, number two program in the country in terms of schools of medicine. So we've really built very strongly on that foundation of strong primary care. On a technology perspective, we really have tried to squeeze every drop out of the Epic platform as possible. We are extensively using Healthy Planet. We have customized it heavily in early years before Epic had a lot of the out of the box bells and whistles and capabilities. It's been a space that we've really focused on. It's been the showcase for us internally in terms of using agile project management methodology. We started our Healthy Planet and our population health journey within Epic right off the bat when we went live in 2014. And we've had a very active set of agile teams working on application build and reporting and analytics. We've been very aggressive in terms of bringing in claims data through our payer partners with our value-based contracts. And we've partnered with the state in terms of making sure that we're exposing all of the community-based services through that can really help address SDOH issues for our patients. We've got a tight connection with the statewide network and platform that exposes those community services and continuing to grow our independent network. We have a very strong performing ACO. We have one of the highest performing ACOs in the country, and we've really worked hard to continue to grow that in a careful and thoughtful way.
What do you attribute the ACO's level of performance to?
I certainly, as a CIO, I want to say the technology.
And as the host, I really want you to say technology, but
yeah.
I realize it's a lot of things.
Well, there's a lot of things for sure. But I will say on the technology angle of it, and I mean this part truly sincerely, that is one of the bright spots across the breadth of the UNC Health system where the clinical and operational leadership really understand the value of partnering with IT. We've had strong partnerships with that leadership team from day one. They've not had a lot of turnover in their leadership, and we've continued to mature that environment. They're the showcase we stand up and talk about in terms of here's how to engage with us. Here's how we can best work with you to drive patient-focused outcomes. And so I really do think we've moved the needle quite a bit in terms of leveraging the technology for our providers and our care managers, especially in the population health space. I saw a statistic from the team. I think Epic may have helped us with this, but I think something like 3.3 million care gap closures we did last year across our value care population, which was amazing. So it shows you we really are using the tools to their, we believe, fullest extent to really help drive our population health forward.
When you said independent providers, it just dawned on me. Do they remain independent and they become like a community connect partner of UNC Health?
So we have all three. So our clinical integrated network consists of UNC Health employed or contracted providers. It consists of some community connect partners. We have, I think, 9 or 10 active community connect partners now across the state. And then we have true independents that are also part of our network that are using other EHRs and other IT not provided by UNC Health, but we integrate with them from a claims perspective. We integrate with them through Healthy Planet Link within Epic, and really do a lot of work pushing analytics through our provider portals and Healthy Planet to those independent providers to help keep that care coordination as tight as possible.
Wow, I'm having flashbacks. That last group that you mentioned, how hard that is to drive the metrics and whatnot into that was I was early on in that process of putting some of that stuff together. It's pretty hard. Now, I'm going to bring just for the record, I'm going to bring the conversation into generative AI. I think it would be cliche to talk about generative AI if it didn't have so much promise in healthcare and wasn't such the center of conversation right now. Yesterday, we had the EU AI Act, which doesn't really impact us in the US, except it will inform what we potentially do moving forward as a government. I don't suspect that the US will regulate it as much, but I'm hearing from people that there's an awful lot of excitement at the promise of AI and also caution as they look at it of where can we put this in place. I'm curious how the conversations have evolved for you in your role.
Yeah, we're all over this from our team. We're placing a pretty heavy bet on this. We were not part of Epic's initial announcement at HIMSS where they announced their partnership with Microsoft and Stanford, and I believe it's Wisconsin and UC San Diego were a part of that pilot for the initial generative AI work around auto drafting responses to patient MyChart messages. But we quickly worked with Epic to be added to that group. So we were the fourth in that cohort of health systems to partner with them. We have that up and running now in our development or test environment with our first set of physicians working with that. And we'll go live more broadly in early August with our environment. We're really excited about that. I think for all of us, we know that's just dipping the toe in the water for this technology, but we're really excited about putting it in front of our physicians and other providers so they can see the power of this. But above and beyond that, we're excited. I hope this week we'll announce more broadly a partnership we've got with Microsoft. We've stood up and have a fully functional internal general purpose chatbot, so an internal chat GPT that is live now and being piloted by the first dozen sets of users. And one question will be, why would we do that? Why would UNC Health want to do that? Well, the reason why is because with that internal chat GPT, if you will, we call it AVA, AI virtual assistant. So AVA, with AVA, what it means is our teammates and providers can really use generative AI chatbot technology without having to worry about, am I putting PHI into chat GPT? Am I putting something that's UNC Health sensitive information? So they can use it much more confidently for whatever they're trying to use it for. We've got our legal team working with it actively to draft legal documents. We've got our physicians beginning to pilot it, drafting patient letters or other correspondence, prior authorization letters, etc. Our internal communications team is beginning to use it to edit or refine or draft initial drafts of communications. So I could go on and on. I won't. We're looking at partnerships with several other organizations now around this. I'm a believer. I think it's going to be a game changer for healthcare. I think we have to be thoughtful and careful about how we use it and how we implement it. We have crafted a formalized set of guiding principles, the first one of which is a human will be in control. We're not going to have any fully autonomous AI within at least the foreseeable future. Is something very important that we think that it needs to be an assistant. I love Microsoft's branding of Copilot. I think that analogy is a brilliant one. And beyond that, we've stood up a group to really help us find a responsible AI framework that's going to bake in trustworthiness, ethics, etc., and make sure we're doing that right. We call that our AAA group. It's our AI and automation advisory group that feeds into our broader information services governance team. So I could probably talk for another 30 minutes about the things we've got going on, but to suffice it to say, we are all over this. We really believe in this. We think it can be game changing for us and for healthcare. We think it can really help improve health outcomes. We think it can help bend the cost curve. And I think early on, it could really help us with provider and teammate burnout.
Is this well, first of all, I love the governance model. I get this question a lot, and we discuss it a lot in our CIO groups of where does AI governance belong? It sounds like you made it a subgroup of a larger group. Talk a little bit about that. Like, why did you choose that route? And then what's the makeup of that group?
Yeah, I think a little bit of background. I think one of the things about every organization has its uniquenesses and their own culture, right? For us, I'm very proud to say our clinical and operational business leaders a decade ago really bought into information services governance. And so I chair our information services oversight committee, our executive function. I'm the only member of our IS team on that group. I chair. Every other member is our system CFO, our system chief medical officer, our system representative from our CEO roundtable from our hospital systems, a chief nursing officer, a chief operating officer from one of our hospitals, and that's a rotation. So we really bring all the different parts and pieces together. And so I think our information services team governance group makes a lot of decisions that are probably beyond traditional IT or analytics. We make a lot of business decisions in that group. Some may criticize that and say that's not how it should be done. It's worked well for us. So it was just a really natural fit as we're thinking about this. To expand on that just a little bit, we've talked a lot over the last few months that really AI is a new and exciting technology and different in a lot of ways, but at the end of the day, how we go about evaluating new solutions, implementing new solutions, supporting new solutions around AI, we don't think it's going to be fundamentally different than other technologies, right? So we're going to use our proven processes, our ITIL, IDLE methodologies, our standard IS practice and solutions and processes. What is different about it is this ethical trustworthiness, bias aspect. And so the reason we stood this group up as a supplement, if you will, to our existing information services governance was to try to address that unique aspect of artificial intelligence. That's the part of this that I think so many across the globe are wrestling with and many are fearful of. So we're trying to make sure we're being very thoughtful about that.
How are you going to measure its success? It's interesting
Yeah.
because I see that this thing is the Wild West right now. It's like all of a sudden, this will probably happen to you. I was talking to somebody, they said, walked into this physician practice and they were using Chat GPT to do this and this. It's like, and that's when the CIO said, oh my gosh, hold on a second. Like, we have to get in front of this. It sounds like you've gotten in front of it, but I'm sort of wondering if we're going to wish we had put a set of metrics on the front end that we can look back on later and say, look, we saved this many hours, we saved this much money, so that we can quantify the use of AI, not just ChatGPT and generative AI in that respect, but all the different forms of AI. I mean, it's embedded in Epic and other things, and sort of measure the impact it's having on the health system.
That's a great question. So the good timing, I actually gave a talk on an update to our executive council just last week around what we're doing. And we're routinely providing them updates. As you would imagine right now, there's so much interest in this space. And so I think we're focused on 4 areas, and I think those 4 areas are going to have different success metrics and criteria. So the 4 areas that we're kind of categorizing things around our AI work are improving health outcomes. There's certainly some things that are going to happen in that space. The one I'm the most excited about right this moment is where we have a emerging collaboration with the American Heart Association and Microsoft around using imaging AI to look through our millions of historical images that we have in our vendor neutral archive to look for where we may have undiagnosed or undetected heart conditions and really try to see if there's things we could do for our patients to do preventative work and make sure their primary care and cardiology teams are aware of what may have been missed before. So that's improving outcomes. Second, burnout. We've talked about that with the Epic work we're doing, and I think that's just dipping the toe in the water to try to help provide some AI-based assistance to our care teams. 3 is experience. I think we can do a lot with our teammates' experience, a lot with our patient experience as AI continues to evolve. We're being a little more careful on the patient-facing AI because that, to me, that's a higher risk. We don't want to damage that relationship with a patient. So I think we're going to be very careful with that one. But I do think we're going to look for trusted partners who are doing proven things, work using AI to help improve the patient experience. And then the 4th is bending the cost curve, right? And I think that's where the CFOs, the chief operating officers are really looking and to say, hey, how can we leverage this technology to eliminate low cognitive tasks? How do we automate processes, leveraging some AI to provide that extra intelligence beyond a basic classic decision tree type technology? So I think those are the 4 areas. I think all of them are going to have different success metrics. And I think we believe, at least right now, that we need to be working actively in all 4 of those spaces.
And that's really interesting. I liken this to when the personal computer first came into the picture. It's like, hey, marketing would like to use a personal computer. Now, we didn't have CIOs back then, so it was, well, in some cases we did, and they would go, a personal computer on your desk, okay. And we started to see them pop up all around. This feels to me like that same kind of thing where people are going, hey, I think I could use this here. They're going to do a pilot. It's going to either succeed or fail. They're going to do another pilot. That's going to succeed. And we're just going to see this proliferate pretty rapidly is what it feels like to me. I'm curious in your seat how it feels to you.
So I agree completely. In fact, so you and I are close in our analogies. I've been for the last 6 or 8 weeks talking to a lot of media groups, reporters or journalists. And as we're working this journey, the analogy I've been using is spreadsheets. So spreadsheet technology, when it came on board, I mean, could you imagine what it would have been like to be a CFO or a finance leader or analyst before the advent of spreadsheets? I don't even imagine, I couldn't fathom how that would have been to do so much of the calculation manually with calculators or other technology. I may be giving away my age a little bit, but
Yeah, you're younger than me because
yeah.
my first job was looking through reams, like stacks. And if people can't see my hands, these things were beyond legal paper, whatever it was called back then, computer paper of Nielsen reports. And people would come over to me. This is my internship. They come over to me and say, "Hey, I need this data compiled in this way." And I would literally go through without a computer and like hand write this stuff and do the analysis and hand it to them. The spreadsheet was amazing.
And to go back to your original point, think about what roles and job functions use spreadsheets. I mean, virtually everybody uses spreadsheets in some capacity within our organization. Our physicians use spreadsheets, our nursing leaders use spreadsheets, our administrative leaders use. I mean, everybody uses a spreadsheet at some point. That's what I think is going to happen with this AI technology. To your point, it's going to sort of permeate ubiquitously across everyone's job function. There's going to be some way that you're going to use this to do your job more productively and probably more efficiently.
This will probably be the last question. How do you ensure that people don't get left behind? You have early adopters and you have late adopters, but how do you make sure that people are aware of what the potential is and bring them along?
So there's a little bit of an aspect of the last thing you just said there I want to touch on. I think one of the questions I'm getting asked a lot now from third parties is, Brent, what's UNC Health stance on being transparent to patients or other third parties that AI was used in some capacity for the given workflow that they interact with? And I don't know that we, as humanity, as a nation, as any sort of unit, have that all worked out. But I think we need to be more transparent than less transparent. I think we need to be transparent that, yeah, this draft was generated by AI, humans still in control, or this was done by an AI component. I think it's important. And I think that can also help with bringing people along, because awareness can breed education about a topic. Beyond that, one of the things that we're doing is we've got our human resources team actively engaged in our AI advisory group. So that's something we want to make sure is upfront, that we're being very thoughtful and careful about our teammates, and that helping everyone understand that this is a technology that probably will be like the PC or spreadsheets to our previous conversation, that's going to be ubiquitous no matter what, and something we all probably need to have some basic understanding of and awareness about how to use. And so my hope is that we can bring everybody along. Maybe that's a rose-colored glasses view, but I'm a pretty big optimist almost pretty much all the time.
Yeah, well, you have to have the glass mostly full as a CIO, because it gets emptied throughout the day. So it's good to start with a full glass. As I'm thinking about that, the interesting thing is the number of places we use algorithms to figure things out or to calculate things or whatever. There's not a lot of transparency. Like I don't ask my physician, "Hey, how was this calculated? Was this calculated using a computer? What type of algorithm?" To a certain extent, as a patient, I place my trust in UNC Health, and I trust that you have the standards and the ethics and the professionalism to ensure that you're using high quality standards across the board. I'm afraid that if you put at the bottom, this was generated via an AI model, then we bring the bias where, think about how we've been trained. We've been trained by James Cameron that AI is going to destroy us someday.
That's right.
And like it or not, there's some people that is their reality, and they're looking at it going, I don't want AI involved in my health. But we know it's not Terminator. It's not a sentient being. It really is very sophisticated computer models and statistics that are being applied to the things we're doing today. Now that could change in the next 20, 30 years, but that's easily how far we are away from a thinking computer at this point.
I think you just made my point that I don't think we have this figured out yet. I think that's what I'm saying. I think there's more transparent than less, but we don't have this figured out. Absolutely. I think If I could make one last point on this, one of the things that we've been talking a lot about lately is the parallel with self-driving cars. We have how many hundreds or thousands of wrecks
Yeah.
that are every day on our highways that were a human's fault. And if a self-driving car makes one mistake, it's going to be dramatically different story. I think the same will apply in AI, right? If the AI makes a mistake one time versus how many times does a human make it the same mistake. So I think that needs to be factored in as well. I think your earlier point, bringing people along, educating people, literacy of AI, these are going to be really important topics. Maybe that's an interesting place to think about new business opportunities right now.
Brent, I want to thank you for your time. Fantastic conversation. I learned a ton. Anytime I learn a ton, I really appreciate the conversation. So thank you for coming on the show and sharing your experience.
Thanks, Bill. Really appreciate it.
I love the chance to have these conversations. I think if I were a CIO today, I would have every team member listen to a show like this one. I believe it's conference level value every week. If you want to support This Week Health, tell someone about our channels. That would really benefit us. We have a mission of getting our content into as many hands as possible. And if you're listening to it, hopefully you find value. And if you could tell somebody else about it, it helps us to achieve our mission. We have two channels. We have the conference channel, which you're listening to, and This Week Health Newsroom. Check them out today. You can find them wherever you listen to podcasts, Apple, Google, Overcast. You get the picture. We are everywhere. We want to thank our Keynote partners, CDW, Rubrik, Sectra, and Trellix, who invest in our mission to develop the next generation of health leaders. Thanks for listening. That's all for now.